Thank you very much for inviting me. When Alphonse asked me to speak about the best bariatric procedure is LAGB, I said I'm not a devoted person who does only these procedures, but he said that somebody has to say that, so here I am saying that. I think that saying that laparoscopic banding is the best bariatric procedure is equivalent to saying that right hemicolectomy is the best procedure for colon cancer, which doesn't make a lot of sense because obesity is a very complex disease. The reason why people become morbidly obese or obese are different. Different patients become obese from different reasons. There is a variety of comorbidities that are different between patients. The patient population is very, very variable. There's a very big difference between somebody who has diabetes type 2 and his BMI of 35 to somebody who is super obese with a BMI of 80 and cannot move from his bed. These are completely different patients. Their problems are different, and the expectations for success or failure of their operation are different. And therefore, there are different goals to the procedure in different patients. And also we have to remember that there's nothing wrong with obese patients' GI tract. There's something wrong with a lot of other things, but their GI tract is usually perfectly normal, and the reason that we tend to treat their GI tract is just because we don't have a better idea. And I think that morbid obesity is a little like other diseases that surgeons treat. It's a very complex disease, and we're treating it with a hammer simply because it works. The treatment should be, if we want to really succeed, multimodal. We can't rely only on surgery. The sicker the patients, usually we need more aggressive treatment. And there again, there are different definitions of failure of success or success depending on the patient's population and our expectations in different conditions. So when we look at the bariatric procedures, what are our goals? As surgeons, we always want to have perfect results, which is to take somebody who's obese and make him into a thin, good-looking person. But that's not really realistic on one hand, and also is not really necessary on the other hand. We know that a lot of the hazards that are combined, that go with obesity or morbid obesity are at a BMI of over 40, and some of them at the BMI of 35. But we also know, and especially this comes from the drug industry, that sometimes the loss of 15 to 20% of your excess body weight may be sufficient to relieve a lot of the comorbidities that come with morbid obesity. And this is just before I start speaking about banding. So what would be the ideal bariatric procedure? We would expect it to be with zero risk. We would love it to be ambulatory. We want it to be very short and very easy to standardize without super skills of minimally invasive surgery to complete safely. We want it to not to have a very complex follow-up. We want it very much not to need the patient's compliance because some of these patients are completely not compliant. We want it not to have late complications, and we want it to succeed in all our patients. Now, laparoscopic banding answers some of these wishes, and I will go through these things, and then I'll go through the things it doesn't work in. I'll discuss them a little. First of all, the safety profile of banding is fantastic. It's excellent. If you look at the Buchwald's meta-analysis from 2004, long-term deaths were 0, and short-term deaths were very, very low, and this represents a lot of early series. I can tell you that in our group, we've done over 3,000 lap bands, and there's 0 mortality, perioperative mortality, 0. We don't give the patients prophylaxis for thromboembolic events. The patients walk around the department 2 hours after they're operated. The procedure is very short. There's 0 or almost 0 tissue trauma, and we think the risk of getting pulmonary embolism from a lap band is similar to the risk of getting pulmonary embolism going to bed to sleep. But if you look at other series, you see sometimes the complication rates are almost alarming. If you look at a very honest group from Insbruck, from Austria, they published their first 785 patients, and this was published in 2006. And you see that out of the 785 patients, 688 had complications, some kind of complications, which is an alarming number. But you see that a lot of these complications are very, very minor. Esophagitis, port problems, port pains, port disconnections, very minor things that may be treated very easily, either with medications or with small procedures under local anesthesia. And even in the same group, they've also published a very large number of patients who needed reoperations. Again, some of these reoperations reflect, I think, their early experience and the fact that the procedure was not done by experts, especially in the beginning of their experience. And the others reflect a lot of small problems that are treated by very simple measures. But again, you see these are really alarming numbers. But there is a big variety of these reports, because on the other hand, from Fielding's group, who do a lot of banding, you can see that the total long-term complication rate is a lot lower. It's less than 10%, which is very much in the realm of long-term complications after other bariatric procedure. It's actually even a very good number if you honestly report all your complications. And other series, for instance, by Mike Rhodes from Norwich in England, who also does a fair amount of these cases, report even lower numbers of long-term complications. So why is there such a variability is something that I'll discuss a little further down the line. But if you look at the profile of morbidity and mortality of laparoscopic banding, you see it's actually a very good operation. Although the results are variable, there are almost no deaths, there are hardly any short-term complications, and there are substantial long-term complications, but a lot of them are preventable. A lot of them are very, very easy to treat, and very few of them are life-threatening. Again, there is a substantial reoperation rate, but again, a lot of these reoperations are small. If you look at efficacy, this is a completely different story. In the early results of looking into the efficacy, the FDA studies that were performed in the States in the late 90s, you see that the loss of excess weight loss was in low numbers, in 30%, 50%, 40% by several groups, but these are early results. European results were better for some reason. But if you look at the papers that were published in the past few years, you see that the numbers are much better. Even in the group from Insbruck that has terrible results in terms of their complications, and that they reported very honestly, you see that their numbers are not so bad. Their patients started at BMIs around 45, which is more typical of the European population of morbidly obese patients. And even at the 7 and 9 years follow-up, their BMIs they're around the 25 to 30, and their excess weight loss is around the 70%. And looking into other series, you see that the numbers are also variable, but you can see that at a large meta-analysis done by O'Brien, which was published a few years ago, the excess weight loss after 5 years of banding was about 55%, and when you compare it to numbers that are of Roux-en-Y gastric bypass, you see the numbers are almost equivalent. They're just slightly lower. So it depends on which series you look at. But if you look at, for instance, a group of 1,000 patients, you can see that about 20% of them do extremely well, 20% of them do terribly, and about 2/3 of them do somewhere in between the 30 to 60 weight loss, excess weight loss. In terms of comorbidities, you can see that the numbers again vary. Some series show that there is normalization of diabetes and hypertension in the majority of patients, but if you look at large series like Buchwald's, you see that although the numbers in banding are very good, they're more on the side of improvement and less on the side of resolution, as opposed to bypass and BPD, where the numbers are more on the side of complete resolution of these conditions. There's an interesting study that again done was by Mike Rhodes, showing that banding is different from other procedures in terms of follow-up. You really need to have the patients followed up closely, and you see that there is a very good correlation between the number of follow-up visits to the outpatient clinic and their weight loss. Patients who visited more than 10 times lost somewhere in the range of 70% of excess weight loss, and the patients who visited only 1 or 2, 3 times lost somewhere in the range of 40%. And in my experience, this is like the rule of thumb for banding. 1/3 of the patients do extremely well. They use this procedure as a life changer. They enjoy being slim. They start going to the gym. They enjoy looking good, and their life completely transforms. A third of the patients do so and so. They are obese. They're not morbidly obese. And most of them are very happy with that. Usually they cut down or stop a lot of their medications, and their lifestyle is fine. A third of the patients do terrible. These are usually patients who are either binge eaters or sweet eaters. The binge eaters vomit, and they're terrible failures. Most of them are reoperated for various complications that have to do with increased pressure in the pouch, and the sweet eaters just don't lose weight. But look at the numbers. In the US, banding has surpassed other operations in the past year. It's actually the most popular bariatric procedure in the United States today. And this same trend is around the world. While in 2003, 65% of bariatric procedures around the world were gastric bypasses. In 2008, it's 42% banding and 25% bypass. And a newcomer is coming, which is the sleeve gastrectomy. In our experience, it's a very nice operation that combines the safety profile of banding with the efficacy that's closer to gastric bypass. But I think that the reason why this procedure is becoming very popular is not the right reason. I think it's becoming popular because it's very, very easy to do, because it's very, very safe, because you can do 12 in a session in one morning and make a lot of money doing it. You can teach anybody to do it. You don't need too much skill. You don't need advanced laparoscopic skills. Once you master the basic techniques, you're fine. And there are very, very short-term complications. It's a very, very good operation, but not to all the patients. You have to select them very carefully. So how do you select the patients? I think you must have, if you're doing bands, a multidisciplinary clinic that follows them and also screens them before the operation. We probably have to devise some kind of a scoring system that will give us a tool to select patients for different operations and to think or to try to learn which patient will succeed in what kind of operation. I think we are lacking of tests that will, both personality tests, psychological tests, and biochemical tests to allow us to know which procedure will work best for which patient. So I think that, to conclude, banding is indicated. It shouldn't be abandoned, but it should be indicated in very selected patients. I think the ideal patients for gastric banding is somebody with a BMI that's 35 to 45, who is motivated and compliant and is willing to adhere to follow-up. I'd like to suggest you to think about other options. I think that in extreme ages, it's a very good operation. In young patients, I think if we can try and not alter the GI tract completely in view of maybe in 10 years, there'll be something else that'll come up. It will be just like our patients that we've operated for ulcer and are now regretting it. We might be good to do a reversal procedure unless they're really super obese. I think in old age it's a good idea. And maybe we have to think about patients who have diabetes and have a BMI of lower than 35, and even patients who are super obese as a first step. So I think the title should be, I'm concluding, banding is the best bariatric procedure for some patients. Thank you very much.